do your intro. Um, I know more people will be coming on, but I know this is a hot topic for everybody, and I don't want to eat too much into Dr. Wallman's time. But tonight's webinar is brought to you through our partnership with DHH's Louisiana Provider to Provider Consultation Line. And the PPCL is a no-cost consultation and education program that assists pediatric and perinatal health providers in addressing the behavioral and mental health needs of their patients. And through this partnership, they've expanded into family medicine. And so we're excited that we actually received a chapter grant. And through this, we are able to bring Dr. Wallman. And then we will also have October, another pediatric mental health topic by Dr. Olivier. But Dr. Wallman is a board certified general psychiatrist and child and adolescent psychiatrist. He previously served as the training director of the Child and Adolescent Psychiatry Fellowship Program at LSU Health New Orleans. While on faculty, he led the consult liaison service at Children's Hospital. He also worked in multiple high schools and provided direct patient care and consultation for school-based professionals. He's an active member of the American Academy of Child and Adolescent Psychiatry. So without further ado, I'm going to turn it over to Dr. Wallman.
Hi, everyone. Thank you. It's a pleasure to be here tonight. I have the meeting chat pulled up on my screen. I'm just kind of positioning it so I can see my slides and see if y'all have anything that comes up as we go. And if I miss it, you can also just interrupt me. This looks like it's a pretty small group tonight, which will be nice to have some conversation as we go. So I thought that this is a topic that's interesting to me. I see a lot of kids coming in to my clinic with anxiety. These days, I'm doing kind of 100% outpatient care. I work both in like a private practice group and also in a federally qualified health clinic where we have like a medical home model. So I get referrals from our primary care docs. And I would say anxiety disorders are, probably the most of what I see. So I thought it would be cool to talk about tonight. I'm not sure why that is exactly. There's definitely this interplay with COVID and everything that came about with the school closures and going back to school, which I think kids with anxiety, that has played into their anxieties. I don't think it's changed the number of kids with anxiety we're seeing, but it's certainly like a big part of what I'm doing now. I put this slide in here. This is about the provider-to-provider consultation line. I have it at the end too, but this is just the info. And right now for the pediatric side of things, it's if you call and have a medication-related question, it'll end up being like talking to me about it at some point. I think we're working on getting another child psychiatrist involved, but this has been a really cool project to be involved with, and it's been really rewarding to kind of troubleshoot some tricky psychiatric cases that for kids that otherwise would be really hard to access psychiatric care. Okay, so here are our objectives. By the end of the session, participants should be able to be familiar with the developmental course of anxiety disorders in kids, identify appropriate tools to screen for childhood anxiety, implement pharmacological approaches, and guide parents to better support kids with anxiety. I have a couple cases interspersed throughout just so we can kind of picture some kids in our mind as we talk about some of the like diagnostic criteria and treatment. I think it's helpful to just have some cases involved too. So this is actually pulled from someone I saw, I guess on yesterday. I saw her yesterday, but I changed some stuff. So Emily is a 9-year-old girl whose parents describe as having a ton of self-doubt. This peaked recently, but has waxed and waned since she was 6 years old. According to her mom, she has so much fear. She recently was too scared to wear her shoes. She said her shoes are too tight and uncomfortable and not weather appropriate. And then she won't leave the house. And then that leads to depression because she doesn't get to do the things she loves. And I think, this family had kind of already tuned in to some of the driving forces that this was really significant challenges with anxiety, but sometimes kind of refusing to do stuff can look oppositional or defiant. So it's not always clear right away what's going on. So the fundamental kind of core issue whenever we're thinking about childhood anxiety is this idea of avoidance. So like, are the kids behaving and acting in such a way that they're being able to avoid something? And figuring out what that is and why that is kind of key to kind of identifying this as anxiety. Usually there's some anticipation of a threat. Adults can say that, like, oh, I'm like, and even adolescents, like fearing test performance, fearing performance on the football field. But for kids, they don't always know what it is they're afraid of, or they can't put it into words. They just know they don't want to do something. And instead, to them, this kind of presents as ruminations, negative thoughts, general worries, and physical complaints are much more common in children than adults. Headaches, stomach aches, nausea, vomiting, diarrhea. And when I am meeting adults coming to me for the first time with anxiety, they may not have recognized anxiety in childhood, but they will identify with like chronic physical complaints, but only are now as adults saying like, oh, I just developed anxiety related to this. But looking back, we'll find other evidence that maybe anxiety was lurking in muscle tension. So there's kind of three main anxiety disorders that we're going to throw under this umbrella of anxiety. There's more to which I want to address, but I think the three key ones are as follows. So we have separation anxiety disorder, and that's a specific worry that something bad will happen to them or their caregivers if they're apart. These kids are often described as being clingy or easily homesick. Then we've got generalized anxiety disorder. This is probably the most common, but I think maybe also overdiagnosed, and maybe we're quick to call things generalized anxiety disorder when there's other stuff going on too. These kids kind of present effectively as being kind of worriers, tense, uptight, inflexible, perfectionistic, may feel this kind of catastrophizing, like if something bad will always happen. Problems falling asleep at night is a really common theme across the anxiety disorders, but particularly generalized anxiety disorder. And sometimes these kids will initially come to me, maybe more often than you would think, is like, oh, my kid has problems focusing and concentrating in school, and the parents are just convinced they have ADHD, when in fact, like, if you start asking questions, they're not really fitting that picture. The last one that comes up a lot for kids is this social anxiety disorder. These kids have fear or worry specifically in social interactions. It can be limited to specific settings, like, group settings, presenting in front of class whenever there's more people involved, but it can be a global problem, like, ordering at a restaurant or walking up to a counter or asking directions on the street. Usually pretty much with strangers, although I've had kids come to me kind of that disclose fears that even friends of theirs at school are kind of always judging them, like in just kind of normal conversation. These kids are often considered to be shy, highly self-conscious, slow to warm up, hesitant to talk in social settings, soft-spoken, and they may avoid eye contact as well. And I think for that reason, like sometimes parents might be worried that something else is going on, like autism. Um, but if you start talking to the kids, they're much more self-aware about this. And it's not that they don't want to have friends or don't value social connections like that. It's just really anxiety provoking for them. These kids too often have physical symptoms when confronted with these social situations. And that could be blushing, sweating, trembling or shaking, feeling nauseous. The other anxiety disorders that certainly come up, but I think are less of a focus in working with children is panic disorder. I have anxiety disorders in quotes, and I'll explain that in a minute. These aren't all exactly anxiety disorders. Panic disorder certainly is. And I think that this is something where kids and parents come in saying, oh, my kid has panic attacks. What I often find is they're trying to communicate they're having all these somatic symptoms where they're having the blushing, the sweating, sometimes the feels like their heart's racing, the nausea, but it's not in the form of a panic attack where it's this intense feeling that lasts kind of a fixed duration of time. Instead, it's just kind of happening throughout the day as an expression of their anxiety. So we usually think of panic disorders as really developing late adolescence, early adulthood in the classic sense of having panic attacks. School phobia is interesting. It's super important to explore when talking to kids and families about anxiety. I think it comes up a lot with social anxiety, kids avoiding school. It's come up a lot more with COVID because it's been normalized to not go to school for periods of time for a lot of kids, and going back has been really hard for some kids with these kinds of anxieties. But school phobia is not like technically an anxiety disorder, and we can't immediately jump to the conclusion that kids are avoiding school because of anxiety. There could be other reasons, although in my experience, it's commonly, although not always, related to a form of anxiety. OCD it's interesting. I still, in terms of treatment and how I think about it clinically, very much falls into this category of anxiety disorders. Neurologically, we've learned that OCD follows distinct neurological pathways that kind of separate it and distinguish it from anxiety disorders. And when they released the DSM-5 in 2013, they separated out the OCD disorders from the anxiety disorders because of this. Our first line treatments for OCD and anxiety disorders are the same, but soon after that, the kind of treatment algorithms diverge. So I think, and like when I first meet kids, like thinking about OCD in the context of anxiety disorders makes sense, but I do like teasing that out because it can sometimes change what I do long term for these kids. The last anxiety disorder I have up here is PTSD. See a lot of kids with various kinds of trauma. A lot of the symptoms, those somatic symptoms they experience, as well as the cognitive symptoms, and the avoidance that are characteristic of PTSD, overlap a lot with anxiety. Again, like first line treatments overlap as well, but conceptually we think of PTSD as somewhat different because it has this unique episodic cause, and whereas with anxiety disorders, that's not the case. These tend to be developmentally driven. We'll talk about like how anxiety disorders come about, but I do think it's important to kind of separate out the OCD and the PTSD here. So we think of anxiety like a disorder is kind of meeting clinical criteria as defined by the DSM-5 as having a 5% prevalence in children and adolescents at any given time. There are more females than males being diagnosed with anxiety at a pretty young age. They say that this kind of separates out from kind of like in school age kids. However, interestingly, like in terms of clinical presentations, it's about 50-50 across the board. And the theory behind that is like that culturally we don't accept anxiety in males as much, so we're more likely to bring them into clinic for treatment. I'm not sure I 100% agree with that kind of rationale, but it's something that's interesting that comes up where we see it in clinic, we'll see like the same number of boys and girls coming to clinic. With anxiety, there aren't really demographic risk factors. This is something that we've looked at for decades. Like, are there socioeconomic things playing into anxiety disorders? Does it matter if you're living with one parent or both parents or grandparents? Does your intelligence matter? Does your level of education matter? Does your family size matter? Does it matter if you're an only child? And none of those really hold a lot of water. Like really what we've come to realize is anxiety seems to operate independent of those things. There are very low rates of spontaneous remission. This is kind of while anxiety symptoms can wax and wane across the lifespan, this is something that often kind of stays with people for a long time. And that's important in thinking about your treatment options and kind of educating patients about if they start a medicine, what that means for them. Age of onset varies for each of these disorders. So usually the earliest anxiety disorders that present are phobias, often in the form of animal phobias. These are specific fears of animals. Like most commonly domestic pets like dogs. And we'll see kids coming in with these sorts of issues like 6 or 7 years old. Separation anxiety disorder is the next anxiety disorder to really present. And this happens kind of in early elementary school. The average is 7 to 8 years, although we see this like kindergarten, first grade sometimes too. Like separation anxiety as a reaction to leaving parents is a pretty normal response for younger children that they work through. It's only when it persists and gets to the point where parents are unable to separate from their kids and really do anything that we label it as a disorder. And that takes time to kind of slowly develop. Social anxiety disorder, maybe this kind of resonates, makes sense developmentally, is that this is like a most commonly kind of rears its head in the middle school years. And I think that this is a challenging period for a lot of kids socially and can lead to kind of kids that are predisposed for anxiety disorders. This is kind of where we see it starting to become a problem for them. Generalized anxiety disorder is probably like, if you look at the average, it's right around there with social anxiety disorder, but I'd say the curve is wider. And it's really across childhood that you can see symptoms of generalized anxiety disorder come up. I don't see like, and certainly in my clinical work, I'm not seeing it kind of dominate in a certain developmental period for kids. It really is coming up across the board. And that's sometimes because, you know, there are different reasons why kids end up seeking care with a psychiatrist. That ultimately brings them to clinic, or where they start to recognize it as a problem, even though it's existed for a long time. Kind of like in our case example with Emily, where she'd been struggling with anxiety, some of these generalized symptoms since age 6, but didn't really decide to come into clinic until age 9, when it was becoming more and more of a problem. And finally, panic disorders. The average, they say, is 20 to 24 years. I certainly have teenagers that come in with veritable panic attacks. but I do think that like it's important to separate out having a panic attack from these more common complaints of somatic symptoms that we see like across the board with kids. I think that to me, this is one of the most important things that really resonates as a child psychiatrist. Like one of the reasons why like I like doing what I do and I find it rewarding is that it's like a way to intervene early with a lot of kids. And anxiety disorders are one of these things that can really have downstream effects, both in terms of interfering with normal childhood development and putting kids at risk for future mental health challenges. And statistically, we just see kids and adolescents, they're at much greater risk for mood disorders, typically depression. There was a recent study where they looked at doing manualized CBT treatment with a group of kids, and then looking at them 5 years later compared to peers who were in the placebo group for that study, and just seeing the likelihood that they went on to develop a mood disorder, and found that doing early treatment made a big difference in terms of depressive symptoms in high school for these kids. Um, Kids with anxiety disorders are also more at risk for behavior problems. It might not be rise to like conduct disorder or oppositional defiant disorder, but certainly kind of set them back and getting in trouble and taking risks that are unhealthy. In adulthood, again, greater risk for mood disorders, and this is more where substance use comes in, as well as suicide. I think this is always a big question that families that come in are, people tend to think of anxiety like, because there's this relational aspect to it, where like we'll talk more about the way parent interactions with kids influence anxiety, but they really are wondering like, am I causing this for my kid? In what way am I responsible? Are there things that I can be doing differently as a parent? And what we find is that's not the first part of that isn't really true. Parents do not cause anxiety in kids in terms of how they're raising their children. Are there strategies parents can implement to help kids cope with and overcome anxiety? Absolutely. But we don't tend to think of it as being caused by maladaptive parenting. There does seem to be polygenetic influences of anxiety. We haven't identified specific genes, but anxiety certainly runs in families, and family transmission of anxiety disorders tends to be specific. What I mean by that is like if one parent has generalized anxiety disorder, their kids are at heightened risk for generalized anxiety disorder, not necessarily social anxiety disorder or separation anxiety disorder. They do tend to follow the specific anxiety features of the parent. And twin studies, where we kind of look at twins raised in other families, find that 40% of these symptoms are mediated by genes. One of the features of like what leads to anxiety, and in talking with families and kids about anxiety, this always comes up, is what were kids like when they were little? And we tend to think of kind of little kid personalities as defined in terms of their temperament. And kids that go on to develop anxiety disorders often have high levels of inhibition in their temperament. What this means is they may be much more likely to withdraw in the face of novelty, less likely to kind of try new things and experiment, much more shy around strangers and peers, just kind of a less positive, optimistic attitude about new things, so which can translate to a lack of smiling, really clingy to an attachment figure, not talking a lot, limited eye contact, and an unwillingness to explore new situations are kind of what characterizes like an inhibited temperament. And a lot of kids that this is something, if you ask families, oh, like what were you like when you were 4? This is often the story I get and the profile I get of kids. So what can we do to screen for childhood anxiety? And I think this is super important for a few reasons. I'll share at the end why I like the scared in particular for this, but anxiety is like what we would characterize as an internalizing psychiatric disorder. So it can really fly below the radar, and unless you ask about these specific symptoms, they won't necessarily be volunteered. Um, and there might not be a whole lot of external evidence that points you to anxiety until you screen for it. And like many parents shocked by the fact that the psychiatric assessment led to this diagnosis, but ultimately found it really helpful to learn this about that was what was driving some of the concerning behaviors and stuff they were seeing with their kids. So here's another case example. Another kid that I've been seeing. Scott's a 15-year-old boy who presents to the child psychiatry clinic. According to his parents, he has severe avoidance. When in social situations, he experiences physical symptoms, a racing heart, sweaty palms, which make him feel physically ill. And he's now stopped going to soccer practice entirely. This kid's like a star soccer player, like sophomore year, was on the varsity team and plays on this travel team. Anxiety is heightened at school, which is now leading to trouble concentrating, constantly worried that he's not learning or that he'll be called on. At home, he's procrastinating with schoolwork, and he can end up very upset at the end of the day. And this is like a classic example of parents will tell me all this, so it's clear they have an awareness and a recognition of his anxiety. But in bringing him to me, they want me to treat his ADHD symptoms. So it takes some kind of backpedaling and education to understand that no, if we actually treat the anxiety, these symptoms that you see as problematic in school are going to get better as well. That's all related, which they, I think on some level they are recognizing, but they want this to be fixed, and they think of ADHD medicines as the tool to fix it. So the GAD-7 is kind of the classic anxiety screening tool that you can use in adults. The questions, like you may be administering this all the time, but it's sometimes nice to just take a moment and read the actual questions for what we're asking people to describe. This is a self-reported assessment. It's just asked of the patient, feeling nervous, anxious, or on edge, not being able to stop or control worrying too much about different things, trouble relaxing, being so restless that it's hard to sit still, becoming easily annoyed or irritable, feeling afraid as if something awful might happen. I think that this is a great, super useful screening tool. I use it a fair amount in my clinical practice. And here's what I like about it. It's quick to administer and score. Like a lot of EMRs already have it integrated. You don't can be self-answered. So like patients can complete it themselves without clinician involvement. Some of the things that make it less useful for me is that it's only screening for generalized anxiety disorder. It's only validated in age 13 plus. I think I'll use it for kids that are younger than 13, but it does require self-awareness of their symptoms. And if you think back to the questions, like these kids that are having somatic symptoms might not even be able to recognize and put in words what the GAD-7 is asking them, even if from an outsider it makes sense that they have anxiety, they might score really low on this screener. So for that reason, it's less useful for our younger, less insightful children, and only great for generalized anxiety disorder, but it's fast and super useful for a large chunk of the patients that we see. Another scale that I find helpful, either alongside the anxiety screening tools, or sometimes this is how anxiety first comes up, is just using the Vanderbilt. This is really geared towards ADHD, and that's commonly what we use it for. But there's also a handful of questions in this subdomain of anxiety and depression, and it's important to look at those questions when you're screening for ADHD. It's also helpful for parents to see and hear what ADHD is, so they can recognize, like, oh, even though my child's having some issues in school, they don't actually have the symptoms that line up with ADHD, so it makes sense that we're pursuing other treatment options. In total, there are 55 questions about symptoms and functional impairment. Those questions are broken down into domains of ADHD, oppositional defiance and conduct problems, and then anxiety and depression. And this is for younger children, so it's validated for use in 6 to 12-year-olds. It can be, like, it's commonly used for kids younger than this. It's commonly used for kids older than this. It matters less the age of the child because the child is not answering the questions. The questions are answered by teachers and parents, and there's no self-report component. This, of course, is like problematic when we're thinking about an internalizing disorder, where it's very possible that the teachers and parents would not be aware of some of the symptoms that a child's experiencing, or kind of their internal thoughts on these issues. That being said, I still think it's super useful. Here are the questions that are specifically, and they don't separate out anxiety and depression, but here are the questions that are specifically about anxiety and depression. So the child is fearful, anxious, or worried, is afraid to try new things for fear of making mistakes, feels worthless or inferior, blames themselves for problems and feels guilty, feels lonely, unwanted, or unloved, complains that no one loves him or her, is sad, unhappy, or depressed, is self-conscious or easily embarrassed. You can see how this could kind of flag some concerns both in anxiety disorders and depression disorders. And I think it's like something that we often are doing with kids anyway when behavior concerns come up, and these questions can help lead us to the right diagnosis. The last screening tool, I say kind of like my favorite for last, is the SCARED. It's freely available for use. It's has questionnaires for both a caregiver and child. Teachers are not involved in this one. There are 41 questions. It gives you an overall score for like an unspecified anxiety disorder threshold, and then breaks the domains of the questions down to generalized anxiety disorder, social anxiety disorder, separation anxiety disorder, panic disorder, or these significant somatic symptoms, which I think is really what it's more useful for. And then finally, the school avoidance. Just so you can get a feel of the quality of these questions, I didn't put all 41 up here, but you can see how these questions compared to our GAD-7 might be able to elicit a more accurate understanding of the child's experience, because they don't require the level of insight and being able to attribute those feelings to what's going on with them. So for example, when I feel frightened, it's hard for me to breathe. I get headaches when I'm at school. I don't like to be with people I don't know well. I get scared if I sleep away from home. I worry about other people liking me. When I get frightened, I feel like passing out. I am nervous. I follow my mother or father wherever they go. People tell me that I look nervous. So I really like this screening tool. I think the screening tools in general, and this one in particular, I think is really helpful for parents to see, because it's kind of concrete evidence that their child is answering questions using a kind of like a validated measure that says, like, because they have these symptoms, we have concerns about these disorders. I have a lot of families that come in and they acknowledge their kids have anxiety, but they think of it more like a personality trait, and they're just so used to it. They don't realize, like, oh, that could be really problematic for the child and their development long term. And instead of kind of engaging in this kind of philosophical conversation with them about what a normal amount of anxiety is versus when it's problematic, this gives kind of a concrete thing that separates it from my clinical opinion to a validated tool that we can point to and say, okay, but because they have these symptoms and they scored this, that tends to land better with some parents, I find. That's true for all the screening tools, but I like this one in particular. It's also, I think, very helpful for parents to see the difference between how they answer the questions versus their children. Sometimes it's very aligned, sometimes it's very different. With all internalized eating disorders, I'd say it's more common for parents to be less aware of some of the symptoms their kids are experiencing. This is like the opposite of an ADHD, where parents will be scoring kids at the highest level and kids will not recognize any problems at all. So I think that for a number of reasons, it's really nice to use a screening measure when you're diagnosing this. You can repeat this to see if it gets better, but honestly, it's not. I don't find this screening tool particularly helpful for like tracking anxiety over time, like we would with the GAD-7. But that's just my take. Some other high yield questions that I just like to, like I'm worried about anxiety or just when I screen, that I think are important to tease out, and they'll might come up in some of the screening tools, but I just like to hear myself and hear what parents and kids have to say. So definitely I delve into the sleep issue and try to find out why. What are the sleeping arrangements at home? They might say, oh, I sleep fine, but I sleep in my parents' bed every night. And that might be evidence of an underlying anxiety disorder, because if they were to have to sleep in their own bed, they wouldn't be sleeping fine. So this idea that they're avoiding places and not leaving the house. So sometimes that, like, it's not, even though this is like an obvious thing that you would think would come up naturally, I find that it doesn't. I think that there's a number of reasons why this is. I think, again, it's like these things kind of happen slowly over time. So the way in which the family is responding to the kids' anxiety is just kind of normalized at some point. So like it might be like, oh, like we never drive on the highways anymore because whenever we do, like Janie throws a tantrum in the back seat and it takes her forever to calm down. So we always take surface roads. And in their mind, it's just become so normal. They don't even think to bring it up. I think the other reason is there's some kind of maybe some embarrassment and shame about those adjustments to their lives they've made that aren't going to be readily volunteered in a first meeting with a doctor. So asking directly is the best way to get at this information. Things you don't like to do, school attendance, and they could in their mind say, oh, it's because they're physically sick all the time. But that might be really, if it's chronic headaches or chronic GI complaints, that might be playing into an anxiety disorder as well. And this last question is something we'll talk about. We're talking about helping parents with this. And they've done studies with this question and have found parents, it's hard for parents to recognize the adjustments they're making. So how helpful this question is, they might not always, even if they are making tons of adjustments, they might not answer affirmatively. But I still think it's worth exploring this, because they might have more insight and be able to share some things that they're doing to accommodate their kid, like not driving on the highway, or not eating certain things, or going to certain restaurants because someone had a bad experience there, and that stuff will start to come out. Okay, let's jump into our treatments for anxiety. And to start, before we start this, I think that there's a lot of just kind of, even among my psychiatry colleagues, this idea that the severity of the anxiety symptoms should determine if medicines are used, as well as if they've tried some form of therapy before getting to medicines. And the more recent evidence really doesn't support that. It's not that that's the wrong approach, but I think that once you can confidently make a diagnosis of an anxiety disorder and it's resulting in some kind of significant functional impairment for kids, like having a conversation about risk benefits for medicines, separate from like how like this precise score on one of these screening tools, or separate from did they already try 6 months of CBT, is perfectly reasonable and really appropriate for a lot of kids. The FDA approvals for anxiety in kids are super misleading, not helpful. For say like a decade, the only FDA approval was for Cymbalta, duloxetine, and that was for ages 7 and up. It is not a first-line choice for, in other words, for generalized anxiety. It's not a first-line choice for any anxiety disorder in kids, simply because its side effect profile is worse than the SSRIs. This is an SNRI, so more likely to have problems stopping it, more likely to have problems with hypertension, more likely to have like dry mouth and some of those side effects. So I rarely will use this, and never first for kids with anxiety, but for years it was the only FDA approved medicine for anxiety in kids. It's only this year that Lexapro was approved for generalized anxiety in kids. This is a perfectly reasonable first choice for anxiety disorders, but it's certainly not the only choice. And there's very good reasons to use other medicines instead of Lexapro. So I don't want anyone to leave here thinking that they have to use these medicines. I'm sure you guys have a much more nuanced understanding of the FDA approval process for the medications available in the US. I'm kind of limited to like just following the psychiatric medicines, and it's interesting that it doesn't really match up with practice guidelines sometimes. And this is definitely one of those cases. So as far as treatment recommendations, the first line pharmacological treatment is always going to be an SSRI. Typically for kids, the ones with the most research and evidence supporting their use, and this is both in anxiety disorders as well as depression, is escitalopram or Lexapro, fluoxetine or Prozac, sertraline or Zoloft. The one, and we'll talk about the CAM study, the one that was chosen to do the big anxiety and OCD studies and pediatric psychopharmacology is Zoloft and sertraline. So that's kind of like what our big or kind of gold standard trial was, using Zoloft. They did a number of these studies like in the early 2000s. So I think that, that's has great evidence behind it, but they even say during the study that there's no reason to think why Zoloft is special compared to our other SSRIs. There may be good reasons to pick the other ones. Really, a child on no other trials of medicine and not taking other medicines, any one of these three is a reasonable choice. The caveat is if you're really worried about OCD, then I don't use Lexapro because it tends to not be as effective because you can't get it to a high enough dose to treat the OCD symptoms. The other thing is like, well, I think it's really useful in terms of educating families and understanding what's going on with kids, which anxiety disorders are at play for a child. There's not like a medicine that we match with like a specific anxiety disorder. So there's not like, oh, Prozac for separation anxiety disorder. We don't have evidence that has specificity like that for these medicines. Whenever prescribing an antidepressant or an SSRI, any medicine that's classified as an antidepressant, really, for people 24 and under, there's a black box warning that comes along with these medicines where they were shown to increase the risk of suicidal thinking and behavior when compared to placebo in short-term studies of major depressive disorder and other psychiatric disorders. So anyone considering the use of this or other antidepressant child, adolescent, or young adult must balance the risk with clinical need. This, has been a big topic of discussion in child psychiatry groups since this issue came up again, or it was around the time that these studies were being done in the early 2000s. We saw a significant decline in the use of these medicines when the black box warning was initially added to the medicines, and a subsequent increase in suicidal behaviors as well as completed suicides, which suggested that these medicines are in fact very helpful for preventing suicidal behaviors and thoughts in most people. That being said, this is like the data does support a significant risk of this, albeit very small. The kids that did have increased suicidal thoughts, they did carry a diagnosis of depression. That being said, I still will go over the black box warning with families when prescribing for other disorders like anxiety disorders. But the studies were really focused on kids with depression. Also, the kids, while they had the thoughts in the studies and they were being supervised closely and monitored, they did not act on those thoughts, which I think is reassuring to families. I still think it's a conversation that you have to have when you prescribe these medicines in kids. And I think it's something I don't take it lightly, but it doesn't kind of change that. I think it's like when a medicine like this is indicated to treat an impairing anxiety disorder, I'm not going to hesitate to use it because of this black box warning. I'm going to make sure the families understand those risks, but I'm likely still going to recommend it. So the 90s, there was this evaluation of the evidence base for psychopharmacology in kids and a recognition that we didn't have great evidence for what worked in kids. We had a lot of like open label trials, case reports, but it was kind of trickle down from our research studies with adults. And industry was no longer motivated to do any of these studies because there wasn't opportunities for exclusivity. Most of the medicines that had come to be recognized as being helpful for children were generic or about to go generic. So they the NIMH made a decision to fund a lot of studies to get us a really solid foundation for understanding the most effective treatment options for kids. One of those studies, and I think one of my favorite of the studies may be this CAM study, and the Child and Adolescent Anxiety Multimodal Study. It looked at the 3 anxiety disorders we talked about at the beginning: generalized anxiety disorder, social anxiety disorder, separation anxiety disorder. The 6-year trial, 6 different academic sites representing diverse demographics across the US. 488 children and adolescents participated, and we looked at 12-week treatment as well as the 36-week durability of treatment, looking at CBT by itself, medication by itself, CBT plus medication, and placebo. All the treatment groups outperformed placebo. CBT alone, Zoloft alone were each helpful, and the combination of the two of them did better than each of those two individually. That's kind of the takeaway. Some of the things we learned: younger children more likely to be activated by these medicines, meaning they kind of feel uncomfortable, on edge, maybe irritable. This is not an indication of bipolar disorder like it might be for adults, but something to monitor closely for and watch. Can mess with their sleep. And it's a reason to kind of back off the dose and titrate very slowly in our younger population. The treatment doses that we found were typically Zoloft 100 to 150. I usually educate parents about that before starting the medicine. And SSRIs are generally well tolerated and effective for the treatment of anxiety disorders in kids. Was, I think, a big takeaway. And it was really agnostic on this question of like, should we do therapy first? Should we do medication first? And I think it's really based on family engagement, and what the family wants to do is often the driving force there. But the study certainly didn't say, and I think the current thinking is not to withhold medication treatment until other things have been tried. That being said, I would quickly want to talk about psychotherapy and what that looks like. It's our last case. Elise is a fourth grader who presents to the child psychiatric clinic with her mother. In first grade, she threw up twice in 1 month, and one of those times she slipped on her throw up on the way to the bathroom. This experience led her to being traumatized. She was too scared to eat out of fear of throwing up, and she would only eat chicken and rice from one particular restaurant, so her parents started getting that for her every night. She started therapy in the fall, and then January 1st of that year, it seemed like it clicked and things got okay. So what is therapy? The evidence really supports doing CBT, which is a skills-based training when we're talking about CBT for kids. It's usually time limited. It takes like 2 to 3 months or 2 to 4 months. There's psychoeducation about anxiety, relaxation strategies, in vivo exposure, which depending on what kids are anxious about, that takes different forms. In the case of someone who has that fear of vomit, it might be initially kind of like looking at pictures of vomit or writing a description of what's in vomit. Sometimes it gets to the extreme of revisiting like real vomit, but that might be hard to simulate. Some contingency management planning, like what to do if you can't handle a situation. Parent training is often, but not always, a part of manualized CBT training for anxiety. Cognitive restructuring, that's the more traditional piece of CBT that when we think about CBT for adults in terms of thinking about their own thinking and how to approach problem solving, that's that cognitive restructuring piece. And then social skills and assertiveness training. When kids engage with this, and that's a big if, it's really hard, but the kids that do go on to complete this, 50 to 60% are considered diagnosis free at the end of treatment. And I'm not sure why the distinction here, what I wrote that, but it has a fairly high rate of success for the kids that are able to engage and complete treatment. Think about Elise. So she did better with therapy, but then COVID happened, and Elise did fine during lockdown. But when she went back to school, third grade was pretty tough. She recently started fourth grade. One kid threw up in gym and one kid threw up in music, which is kind of an unfortunate coincidence with her past symptoms. And initially, she started refusing to go to those classes. Then she started to refuse to go to school altogether. And all she could think about was herself throwing up or anyone else throwing up. And she has 3 older siblings, and her family feels like they have to tiptoe around her at home. So what can we do to guide besides CBT, which was initially helpful, but maybe not for every kid, and not all kids are ready to engage with that, and not all parents and kids are open to trying medicine or will respond well to medicine initially. So how do we help parents? And it really is focusing on like these accommodations going on, and there's more and more research that supports this. And accommodations are ways in which parents and other family members change their own behavior to help their relative with a psychiatric illness avoid or alleviate distress related to the illness. So in Elise's case, it was her parents getting the food at the restaurant. It's letting her not go to those classes anymore, letting her stay home from school. These are all examples of accommodation. So how do we help parents work through this? And there's kind of training programs for this. And in particular, this guy, the psychologist, Dr. Leibowitz, has put together treatment programs for clinicians, but also manuals for parents to use, which I think is a really helpful resource when kids don't have access to therapy. And it's parents learning the skills to help their kids with anxiety. And it's thinking about things that the parents can do at home that don't really require changing their kids' behavior. It's really focused on the parents changing their own behavior. The two main things that are happening are being able to respond more supportively to kids when they're feeling anxious, but then also kind of incrementally and simultaneously reducing the accommodations. So being supportive doesn't mean you get to stay home from school. It's being expressed through verbally and through compassion, but behaviorally, how do we get kids to where we want them to be? And it's reducing those accommodations. This is the end of my talk. We have a few minutes for questions. I want to point this out, and this is in your slide deck. This second reference is a great textbook that's available for free online, put together by the International Child Psychiatry Organization. There's a number of these medication guides put together by ACAP. If you type in like parent medication guide, you can find them. And this one it's pretty good for the anxiety disorders. I just wanted to draw your attention to those resources when you're dealing with child psych issues. And lastly, we've got this slide again. So please don't hesitate to reach out if you have clinical questions that come up. It's sometimes much faster to make a call and talk to someone than it is to do a Google and your answer. Like there might be a million answers that come up through UpToDate, but it might be easier to just talk it through. So I really encourage people to use this. I think it's been, I can't say what it's been like on the receiving end, but I've certainly enjoyed it, and I think it's had a positive impact for those that have used it.
Dr. Wallerman.
Yes.
Thank you so much. That was very comprehensive in the amount of time you had. To appreciate that. My question is, what is a contribution from current social media, iPhones, iPads, et cetera, as communication tools? The children may come out not being as comfortable face-to-face situations like classroom proms, sporting events, and whatnot, because now they're physically together and face-to-face. And I guess it could make them feel more vulnerable. What are your thoughts on that?
Yeah, I think that it's an important question that if you come to like one of these child psychiatry conferences, there'll be a number of talks specifically on this issue because it's become a much more important thing in our work. And I think we're still trying to understand it. The initial, like the research that there's some compelling research that links the rise of social media and the rise of kind of kids having iPhones to prevalence of psychiatric disorders in children, which is suggestive that there might be some causal relationship. Most people are resistant to that idea. I do think that like for a lot of kids and talking with them, the expectations set by social media can affect kids' self-esteem. I think as you point out, sometimes social media and kind of connecting with peers online for anxious kids is used as a tool to avoid real life interaction. So they're gravitating towards those sorts of interpersonal interactions instead of doing stuff in person. Or they might be using it as an escapist tool. So they're avoiding interactions entirely and instead just spending time online. And I certainly see that. So I think looking for patterns like that and asking how much time kids are spending online is an important part of this. The other research shows that like not all engagement online is bad, and perhaps there's like kids that spend a lot of time playing games, interacting in that way. There might be some positive things that come through that. So I think it's an important aspect of kids' lives that we're still figuring out. I will say that like this COVID and this normalization of doing so much online, I think has really impacted kids that are vulnerable to anxiety in all sorts of ways. And they're still kind of trickling into clinic, you know, even though they've been back at school for a couple of years. There's like some real developmental milestones missed as a result for a lot of kids.
Thank you.
Another question about the influence of social media and screen time on autism. It's a great question too. I think that, you know, diagnostically, like if I'm exploring kids with high functioning autism, like understanding what they're doing online, it can sometimes be helpful. Like we think of certain interests and behaviors, like historically kids that were gravitated towards kind of like engineering toys like Legos might link more with thinking about, oh, do they have other traits that make them have this neurodivergent profile linked to autism? And some kids are engaged. So like understanding what it is that they do online is important because it tells us like, are they engaged in like that imaginative play or social interactions, or is it more of these kind of construction engineering like things that they're doing? I don't know if it like exacerbates autism symptoms. I will say the patients that I treat with autism, their parents say like kids with autism have trouble with transitions, like if they have to stop doing something and move on to the next thing. That's really difficult for a lot of kids with autism. And a very frequent example is getting kids to stop playing video games. So how that plays out in the household, I can see that it's a challenge for kids with autism, but I don't think it like changes the core symptoms of autism, but I think it plays a unique role in their lives often.
Does anybody else have any questions for Dr. Wallman? Okay, well, seeing none, Dr. Wallman, thank you so much. I know this was a very pertinent, relevant talk. Thank you for doing it. And just one last thing about the provider to provider line, everything is free, right, Dr. Wallman?
Oh yeah, absolutely. And we you know, it's usually during business hours, but you know, we've been able to we've never not been able to find a time that works for people to connect. So it's free and it's pretty quick, and I would argue that it's just like, for me, if I'm trying to look something up or find out how to do something, I think it's an efficient way to get a good answer for a clinical question.
Great. If there's any questions afterwards, you can get in touch with me because I do have that information, and I think Dr. Wallman had put that in the slide deck as well. Well, please complete your evaluation for our AAFP members. I will report your attendance tonight for you. And again, thank y'all. I appreciate it. And check out next month's webinar. Acute pulmonary hypertension is the update. All right. Thank y'all.
Okay, bye. Thanks for coming.
Bye. Thank you.